Welcome to Don't Be Rash, the Pediatric Dermatology Show, the owner's manual for your kid's skin, and the official podcast of the Society for Pediatric Dermatology. I'm your host, Dr. K, board certified pediatric dermatologist and father of two boys myself. I'm here to chat with you to promote dermatological education and improve your skin health in our children everywhere. Let's get started. On today's episode, I'm pleased to be joined by Dr. Jillian Rork, pediatric dermatologist at Dartmouth Health and assistant professor within Dartmouth School of Medicine. I had the pleasure of recently seeing Dr. Rork give a lecture to the society on her experience working with patients with Down syndrome, and I thought it would be wonderful for her to share her experiences on this new platform. Welcome, Dr. Rork. Thanks for joining us today. How'd you find yourself focusing on Down syndrome as a clinical niche?
Well, thanks, Dr. K, again for inviting me to talk today. It goes way back, I think, to my grandmother, who is dedicated to taking care of people with intellectual and physical disabilities. And then my mom was a physical therapist at Easter Seals.
Mm,
We used to go to work and hang out with her and go to the Easter Seals fundraisers. And, just from an early age, really was exposed to the Down syndrome population. And I think I knew early on that I wanted to do something with them and advocate for their community. When I was a pediatric intern, I had the opportunity to spend a month with Dr. Brian Scottco at
mm.
MGH in his Down syndrome clinic. I'd kind of started out with that rotation being like, well, I know genodermatoses are a really big deal. I should go hang out in genetics. But then was placed in the Down syndrome clinic and just noticed all of their skin conditions and kind of went back to the literature. And, I could read about elastosis perforans or piginosa, but like nobody was talking about this horrible folliculitis HS stuff. And like,
Right.
why do 5-year-olds have horrible onychomycosis? So I think it was really a merge of like identifying pathophysiology that really like needed to be described and researched,
Mhm.
and then advocacy. Like these patients were suffering, and so often I heard from them and their caregivers like no one's paying attention to their skin. And then kind of anchoring in, a family I think that has just been dedicated to helping this community. It all just kind of like came speeding together.
That's amazing. It's
Yeah.
amazing.
So, yeah.
For the audience's sake, can you review what we understand currently about Down syndrome? What causes it, and maybe speak a little bit to the underlying pathophysiology?
I think Down syndrome is kind of really a beautiful display of like genetic personalized medicine, right? Like it was a long time ago that we identified that Down syndrome was caused by a trisomy of chromosome 21, meaning that you have three copies of that 21st chromosome. And then over the years, identifying the genes that are on that chromosome. And truly, Down syndrome, it's a 1.5x gene dose. That's kind of it. Now, I always say, guess what? You have all the other chromosomes too, but that third copy of the 21st chromosome really can have a profound impact on health. For us in dermatology, and I would say we're discovering new things all the time, but there's some pretty identifiable genetic characters, shall we
Mhm.
say, on the 21st chromosome, specifically with the immune system. So interferon is heavily present on the 21st chromosome, especially interferon receptors. So we have 6 interferon receptors that we're kind of aware of. Well, 4 out of the 6 genes for those
Mhm.
interferon receptors are on the 21st chromosome. Amyloid has long been known to be present on the 21st chromosome, specifically amyloid precursor protein. And there's been a lot of emphasis on that with, really kind of one of the more prominent conditions in Down syndrome, which is early onset Alzheimer's, and the role that amyloid has with that. But amyloid also has a lot of impacts on the skin. And then APOSED, right? Going back to our dermatology boards,
Well,
with
thank you.
the APOSED gene is on the 21st chromosome. And, I think back to, I was a pediatric intern. Gosh, I got to think about this in 2013. And I feel like a lot of this wasn't even really being talked about. So who even knows where we're going to be 10 years from now? But, again, that thought of like personalized genomic medicine, Down syndrome is like really such an excellent example of the advancements that we've made in the lab and how that's translated to phenotypically what we see in the clinic. And then now, hopefully, translating even further to potential targeted treatments for our patients.
Down syndrome is for me one of the examples that I give our residents when I have a moment of vulnerability and explain to them how times have changed since I started in pediatric dermatology, where Down syndrome plus probably 100 other things I've had to say, we don't really understand why that happens. And then it's like, yeah, we do now. And then sometimes I don't know. And the residents keep me honest and they go, actually, Dr. K, we figured that out a couple months ago. There was a great article. You should probably read that. And I go, okay, yeah, that's great. And Down syndrome, now with the different conditions that we both heard you talk about at SPD, but also that have come out in some big articles, CME articles dedicated to Down syndrome and dermatology. It's really shed some light on this important topic. You mentioned folliculitis. I know on our maintenance of certification exam, I recently had to pick from a slew of the articles, and one of them that I selected was the link between Down syndrome and folliculitis and maybe the underlying pathophysiology around that. Do you want to start with that clinical condition and kind of walk us through what folliculitis is and how it's different in a Down syndrome population?
Yeah, I mean, there's a lot of things to talk about. So folliculitis tends to happen a lot earlier in individuals with Down syndrome. So where we would think of it as more of like an adolescent adult condition, I have kids who are 6, 7, 8 years old coming into my clinic with pretty profound, quote, folliculitis, especially on their buttocks and their thighs. For a long time, there was the thought that it was infectious, right? That it was a
Mhm.
bacterial folliculitis, but as many of us have found that for a lot of people, it's sterile. Nothing is going to be growing on there. Um, and I think that this kind of goes back to what we were talking about with amyloid precursor protein and potentially interferon, that this is a um, kind of pathophysiologically complex condition that involves follicular occlusion, potentially from the amyloid precursor protein, because we see that in mouse models that amyloid can really stimulate that. And then this whole question of interferon playing this inflammatory role for it being an inflammatory skin condition. Um, what is really interesting is that I think folliculitis, hidradenitis suppurativa, it is a spectrum condition in people with Down syndrome. It's not that you have one or the other. I mean, I
Right.
think maybe I have a few patients like that, but they kind of like are on this phenotypic spectrum, with many of them potentially starting with, quote, folliculitis when they're younger, and then you will watch them and they will grow, or they will develop, I should say, larger inflammatory nodules, pustules, and then even sometimes, into sinus tracts.
Mhm.
They definitely are on the more follicular nodule spectrum of hidradenitis suppurativa, and I know there's been a lot going into describing HS phenotype better, but it's like it when you see it in people
Mhm.
with Down syndrome. It looks
Absolutely.
different than a lot of our other patients. There's a lot of buttock involvement, which
Yep.
is incredibly difficult on quality of life, and especially with exercise. Um, and so yeah, so I don't really think it's an infectious process. I think it really is driven by some of those big players on the chromosome. And I think, more than ever, when you have a patient with, quote, folliculitis, you
Mhm.
need to be monitoring them to make sure you know exactly where they are on that phenotypic spectrum and that you are not missing, hidradenitis suppurativa. Now, I don't have enough clinical data to show this, but I feel like when I control it better when they're younger, like you have the potential to impact,
Mhm.
their progression of that phenotype. And then
That's interesting. Yeah.
lastly, I'll just say, the US and Canadian HS foundations were so overwhelmed by kind of the prevalence data, and also
Mhm.
I just think like clinical experience with the prevalence of HS, that they recommend screening people annually with Down syndrome, no matter what they walk in your office for, and I would say a lot of the Down
Hmm.
syndrome clinics have really taken this very seriously, and they are screening for signs of HS folliculitis in patients. There was no age that was given on when to start screening, but
Okay.
our advocacy group has said, hey, like, it's such an easy screening, right?
Yeah.
Like you're looking in the armpits, you're looking at the bottom, you're looking at the thighs,
Right.
albeit you have to be respectful with those private areas. That's like a pretty easy screening test. And so why don't we start younger? Why don't we start, 8, 9, 10 years old, looking for it? Because I've certainly seen patients that young in my clinic for those skin conditions. So,
Well, I'll tell you absolutely that age, but even younger. I have two
oh
patients.
yeah.
You're right. I have two patients now. One was 5 when I first discovered that she had folliculitis and HS overlap, and the other was 6. The
Yep.
problem with that, maybe you see where I'm going with this, is treatment options, right? So, how do you approach treating the folliculitis component? What's your sort of go-to ladder for that?
Yeah, so I think a lot of the latter depends on the age and the compliance with like
Mhm.
what we're going to be doing, with personal hygiene. Meaning that I spend a lot of time once I diagnose something being like, okay, so who helps with bathing? Do you like to take a bath? How long does it take? Is it relaxing or stressful, right? Because a lot of our tools that we'll use in the beginning are washes
Mhm.
and they're topicals on the skin. So, if someone does not like to take a shower, and there are a lot of reasons why that might be,
Mhm.
namely that a lot of people with Down syndrome have issues with their ears and they have a lot of hearing loss, or they have hearing aids, and it's or they have recurrent ear infections, and so they do not like the way water feels when it hits their ears. Okay. Now,
Yeah.
there's lots of ways around helping that in the shower, but if they're predominantly hanging out in the bathtub, I use a lot of dilute bleach baths to help and explain the science behind that. Um, and try to soften the name bleach bath, which sounds horrible.
It does.
But we'll use that.
Yep.
I definitely found during COVID, when a lot of my patients were not allowed to be in pools, because not to generalize, but many of my patients love to swim. They love going to the pool, that I saw a lot of worsening of their folliculitis. Now, that could have been multifactorial, but I do think that swimming in the pool is helpful too for a lot of that. Now, if they are, um, if they're more inclined to take a shower,
Mhm.
I oftentimes will start with benzoyl peroxide wash, and I usually go right up to 10%. I
Really?
have
Okay.
had more success with that than Hibiclens. I have a lot of patients who come to me and they're like, I've tried Hibiclens and it doesn't work that great. There's
Yeah.
also a lot of foaming benzoyl peroxide washes, which the sensory feel of those is a lot nicer and they're a bit more friendly to apply. Um, I've also started to use hypochlorous acid a bit too for people where it's just like a real struggle. We can't get in the bath or the shower only once a week. It's a
Mhm.
real struggle. I have started to use more of those too. Kind of,
What are
I don't
you?
know yet.
Well, I was going to ask, what do you feel is the advantage of that over a benzoyl peroxide wash, for example,
You don't have to put it on in
in the shower?
running water.
Right. Yeah. Right.
And sprays are kind of a little bit more engaging and fun,
Hmm.
like they're a little bit easier. So, now in terms of topicals that are placed on the skin, this is again where I spend a lot of time being like, this is what an ointment feels like. And even,
Hmm.
I have generic Vaseline in my office and that's it for quote samples, right? And so we see what that feels like. We talk about maybe what a lotion will feel like, but how those might sting or burn. And then we talk about what creams feel like. And then lastly, solutions. A lot of people come into me having been given solutions, and those sting and burn
Right.
when you have open spots of folliculitis. And so, we talk through that, and that the main thing with our treatment plan for the skin condition is that it feels good, it's practical for your plan, and you feel empowered that you can play a role helping with it. So, when it comes to the topicals, I would say clindamycin lotion is kind of the workhorse for
Not
me.
the solution.
I don't love the solution.
Yep.
The dabbers, I don't know if you have ever received clindamycin solution.
Mhm.
It's kind of funny how it comes out sometimes and it burns,
Yeah.
for a lot of patients. If we want something that's like a quick dry, kind of more of a solution, if you can get them covered, the erythromycin paget are
That's
nice
good.
because
Right.
those are like little wipes and
Throw
they're
them
just
away.
easy. Yeah, throw them away. Even though we don't like to be wasteful, but And then, and then and I talked about this at the SPD. There's not a lot of science behind this, but I have a lot of adult patients who have folliculitis and they also have rosacea. That's like a whole other, well, maybe there's something going on there. But I've repurposed some of their metronidazole before and have found it pretty helpful. I
Hmm.
think that kind of speaks that we need to be studying the microbiome of their skin and like how all this, kind of unique inflammation impacts that. Um, and then I use, and this is kind of going more into the HS, realm, but I use a lot of resorcinol because they are more follicular nodule. They have these like isolated lesions. And if you can apply resorcinol on those bigger spots, twice a day for a week or two, oftentimes it nips them pretty quickly. And then lastly, I'll just say I have some patients who are certainly more comedonal predominant folliculitis,
Yeah.
and I will use topical retinoids. And I
Mhm.
typically start, at the 0.05%, 3 times a week, just to kind of minimize application and minimize dryness. But I really like to try, we're all as dermatologists, we're morphologists first, right? So like really try to understand the morphology that you're seeing. If you're seeing predominantly comedones, again, a benzoyl peroxide wash is going to work better than Hibiclens. A topical retinoid is
Sure.
potentially going to work better than a topical anti-inflammatory antibiotic.
One problem that I've had with the bleach baths and some of the other topicals that we mentioned, especially the retinoids, is just how drying it is. What's your
Yeah.
what's your approach for moisturization in these patients after they put
Yes.
those medicines on?
Sure thing. So, if I'm using clindamycin lotion, I oftentimes find that that is like some,
Yeah, that's probably
a
fine.
moisturizer. If you're using a topical retinoid, I always have people follow it with a a moisturizing cream. There are moisturizing creams out there that are non-comedogenic, right? That aren't just for the face, that are creams and not lotions. And so, we talk about that, like what a non-comedogenic means, and talk
Mhm.
through some of the brands available. But a topical retinoid, and I would say this is even in my routine practice, I'm like, you know what? When you put it on, just put on a little bit of moisturizer, even if you quote, don't think you're dry, because it's kind of like a snowball, and all of a sudden you've got a big mess
Right.
and it hurts, right? So,
What is your sort of latter approach to treating the HS component? And what
yeah.
difficulty have you had? Because when we get into the biologic realm, that's where I get blocked both by the age indication that's where I mentioned the 5-year-old earlier, and just what options are out there for 6-year-olds or 7-year-olds who've got bad enough HS warranting a systemic medication, and I'm having a very hard time, even when they're age approved or should be, getting insurance to cover that. But what's sort of your ladder?
Yeah. I spent a lot of time on the phone with insurance companies. In fact, it was somewhat comical that I came back from the talks that I gave, and on Monday, what did I have but a PA call with an insurance company where I had to fight with
Yay!
them for a half an hour about why I wanted Cosentyx for a patient. I think it's the same thing that, Dr. Cotton and, Dr. Corrales, so many of our colleagues in pediatric HS are like, we need to pay attention early rather than late,
Mhm.
right? And there's a lot of potential off-label use here when we're talking about biologics and younger people. So, I would say in some, just to kind of talk about like female teenage patients, I will start with, some of the hormonal treatments, spironolactone, talking to their medical team about combined oral contraceptives,
Mhm.
talking about metformin.
Mm.
I have seen that helpful. I do not prescribe GLP-1s. I have some patients who are on them with Down syndrome. That's kind of like a newer realm, but I think that that potentially could help with skin. I use zinc gluconate in my
Mhm.
practice and actually have found that quite helpful. You need to be careful with GI upset. There, I definitely had that when beginning with kind of higher doses like the 90, 100 milligrams that you'll read
Mhm.
about. I tend to start with 30 and
Okay.
then very gradually go up. And if it's helpful and you're going up, you always have to remember to add in some copper.
Mhm.
Um, and then in terms of the biologics, this kind of goes into what Dr. Espinosa and a lot of people in Down syndrome are working on, which is like, again, really thinking about the immune system pathway and the reason why these skin conditions are happening is is unique in somebody with Down syndrome. So some of the biologics that we would see work in someone who only has two copies of the 21st chromosome are actually not going to be effective. And if anything, might even be like hurtful for somebody with Down syndrome.
Hmm.
So, right now, the biologics that I predominantly, we have available to us, right, are like a TNF alpha,
Mhm.
adalimumab, or an IL-17 like Cosentyx. When we're able to get things through right now, I advocate and fight for an IL-17 a
Okay.
lot more than a TNF alpha
Mhm.
because of clinical experience with it not being very helpful for their HS and also psoriasis and even having paradoxical
Yeah.
flares, on TNF alphas, and we know that those paradoxical TNF alpha flares are actually interferon driven. I like went to a couple talks at the AAD about that, and I'm like, yes, it is.
Yeah.
I think so because we see that in our Down syndrome
For
patients.
sure.
Um, Oftentimes, at least in the state of New Hampshire, many insurances will require that you do TNF alphas first. And I just say, like, get me somebody on the phone. Get me somebody on the phone and I want to talk to them. We are working in our research community to try to capture this better in publication so that you guys have something to show to the insurance company. There was in I mentioned this, I think, on the SPD talk. There was a nice case series out of Ireland a couple years ago showing that 80% of people with Down syndrome and psoriasis who were given a TNF alpha failed that treatment and
Mhm.
required conversion to another. Okay. So yeah. Now, I think like we have to pay attention to the systemic JAKs, right? And this is where a lot of the research is going into with Down syndrome. And obviously, they're off label right now for HS, but I think that that's going to change pretty
Yep.
soon.
Looks
But
like it might.
this is, yeah, so this is more mechanism specific for a lot of the immune pathophysiology for people with Down syndrome and their skin conditions and potentially has profound impact on other health conditions that they have because we are thinking more and more of Down syndrome as an interferonopathy,
Mhm.
and so it affects their thyroid, their other autoimmune conditions, their cognitive decline, especially with memory loss and Down syndrome regressive disorder. So, I feel for us right now because, like, we have made some discoveries. We can't really translate all that much to, like, getting those drugs. But I would say, kind of in summary, like, walk the ladder for female patients with some of the hormonal treatments.
Mhm.
Think about metformin. Think about zinc. Do not grab for chronic antibiotics because I don't really find that it works that great. I use them episodically,
Okay.
for big flares sometimes, but they have a lot of GI impact on their belly. And a lot of them have been on chronic antibiotics for all of, their sinus and ear infections. And then don't be afraid to think about the biologics younger. You're going to have to get on the phone to try to maybe sidestep a TNF alpha a little bit more towards IL-17. And then we got to keep our pulse on the JAKs because I think that that's really going to provide excellent, treatment options for
Mm.
them and probably be the most efficacious thing that we have out there right now for them for their, complex skin issues.
I really wanted to focus a little bit more, Dr. Rourke, on your approach to spironolactone. That's where I train out on the West Coast. My feeling over my training period is that we don't do that as much out on the West Coast as maybe the East Coast does. And having now
Mm-hmm.
come back to the East Coast and been here for 9 years, I've added this, especially to my acne vulgaris armamentarium, but I'm still a little gun shy. So walk us through your approach to spironolactone for Down syndrome patients who are suffering from HS or folliculitis.
Yeah. Yeah. So I think to start out, going on a systemic medication or prescribing systemic medication in somebody with Down syndrome, I like to think of it as a team sport, right? Because like we got to think about their entire care team and other reasons why they see the doctor. So, going through the side effects for spironolactone, I think it kind of touches on like who you might need to talk to and the big questions that you need to ask. And so for one, many people with Down syndrome are born with a congenital heart defect. So, and a lot of them will have had a repair from that when they're younger. So, when we're talking about putting them on a medication that can affect blood pressure, we need to like talk with their cardiologist and make sure that they're okay. Some of them will also have a history of a kidney condition. And so just asking that simple question, have you ever had any issues with your kidneys? Okay. Um, and then also, like, you need to get an idea what their menstrual cycle is like. Is
Mm.
it irregular? Is it irregular? How is that being approached with either your primary care doctor or your gynecologist? Okay. Now, it is ubiquitous. And in fact, I'm like working on a research project about
Mm.
this right now that people with Down syndrome have lower blood pressures. It's really, it's been now well published. And I think, man, I tell you, working on this research project, like very notable that
Significantly?
yeah, they
Yeah.
live pretty low, about 10 to 15% lower
Hmm.
than the general population. So with that, I oftentimes start lower with spironolactone. So if I were to see a patient, in my office for acne or folliculitis, HS, who's in the general population, I might start out at like 50 milligrams once a day for 2 weeks and then escalate them up to 50 milligrams twice daily.
Sure.
And I know I went to Dr. Barebi's talk at the
Yep.
at the AAD, like that's, kind of what we standardly do for acne. Now, with Down syndrome, I tend to start at 25 milligrams once a day. We'll
Once a
see
day.
them back. Yeah, we'll see them back maybe in about 6 to 8 weeks. Less so looking for clinical impact yet because
Mhm.
spironolactone takes some time, but really trying to understand, are we having any side effects from it, like taking
Sure.
a good repeat blood pressure. I spend a lot of time talking with them, but also their caretakers of like, what are some of the symptoms of feeling lightheaded? Are we
Mhm.
slower to get up? Are we a little more unsteady on our feet? How good are you at drinking water? Are you going to the bathroom a whole lot more during the day? Have you noticed that you've been going to the bathroom more at nighttime? And just making sure that it does not have
Mhm.
an impact on them. And then I will slowly escalate, usually again by 25 milligram increments rather
Okay.
than 50, which is again kind of more what I would gravitate toward in the neurotypical population. And then, but oftentimes I haven't found that I've needed that much spironolactone in patients. Now, I have some who are on 150 milligrams a day, and
Mhm.
they're doing okay, but that was with the slow escalation. I have others who are on 25, 50, and it seems to be quite helpful for them.
And you
Mhm.
do, just to be clear, you do find spironolactone can play a positive role as a treatment? Yeah,
Yeah,
yeah.
yep, I do. I
How
do.
how do
Mhm.
you approach deciding if you're going to do spironolactone and or a birth control pill? Is there a role for OCPs in this
Yeah,
population?
oh, definitely. I've had combined oral contraceptives be helpful too. I mean, I'm a bit of a purist. I don't love to start two new systemic medications at the same time, right?
Agreed. Yeah.
And so, if we're making a decision to those, then it again is really speaking to like this is a team sport.
Hmm.
What else do we have going on with our menstrual cycle? What other endocrinologic conditions do we have going on? We're going on a combined oral contraceptive could be helpful.
Hmm.
Um, and so, yeah, so, it's interesting, quite a few of my patients where I've prescribed spironolactone, they're already on a combined oral
Okay.
contraceptive. So
That's
I
what
feel
that's what I was
like,
wondering. If is there
yeah,
one that you tend to
yeah,
start first, or
yeah, I would
maybe?
say like, and somewhat by default, I tend to start with spironolactone because they're already on,
Okay.
a combined oral
Yeah.
contraceptive. But what is so incredible to me. And I just always, I'm scratching my head right now. I scratch my head about this. There is such a lack of research in people with Down syndrome. Like, it's just unbelievable. And there's not a lot about combined oral contraceptives in them and the side effects of those medications. I mean, there's just not
Mhm.
a lot about menstrual management in that. And I know that the Down syndrome community is trying to change that, but like I've had patients have, deep vein thromboses on combined OCPs, like these
Mhm.
things happen and they're not smokers,
Right.
and so, and I think I at least said this in my AAD talk, like in my regular pediatric dermatology practice, I'm the one who signs the prescription for the combined oral contraceptive.
Yes.
I it's a team sport when it's my patients with Down syndrome,
Mhm.
because I want to make sure that I really understand their entire, medical history. What are we trying to gain from this, not just from the skin, and really make a collective decision together.
And when you
Hmm.
say team sport, does that mean you're involving other specialists or
Yeah,
and
yeah,
right?
their
Yeah.
primary care doctor, their gynecologist. Hmm.
Neurologist? Are they seeing a neurologist for stroke risk or anything like that? Or
No, so interestingly, with the exception to Moya disease, man,
Mhm.
that's going right back to medical school there. Like the stroke risk is not
No higher.
significant in people with Down syndrome from what we know. Um, I mean, they will have neurologists more for, seizure conditions,
Mhm.
but not as much for stroke unless they have Moya disease, which is a very, particular type of stroke. Um, so yeah, so it's mostly PCP, gynecologist, endocrinologist when we're talking about combined OCPs. Yep, more cardiologists, nephrologists when we're talking about spironolactone. But don't be afraid to use these medicines. That's the thing. Like sometimes I get that sense from my patients. They come in and they're like, "Why did no one ever talk to me about this
Right.
stuff?" And so I always say, like, you're gonna pretend like you're at your favorite restaurant. You're gonna hear everything on the menu. You might think that special sounds awesome and you want to order that special, or you might think, gross, I don't want the mac and cheese. Like that's great. You don't have to take it, but you at least need to be talking about these options for your patients.
How about autoimmune conditions? Let's dive a little bit into the two that specifically you gave a spotlight on at your talk, alopecia areata and vitiligo. Where
Oh,
do we start
yeah.
with that?
Yeah. Yeah, so alopecia areata, the data is pretty striking in terms of how much more prevalent it is and that
Mhm.
it starts at a younger age. Vitiligo, it's certainly there. I don't think the numbers are as quite as striking in terms of increased prevalence, but I have a fair number of patients who have both,
Mhm.
alopecia areata and vitiligo. Um, and so, one of the big things that we've tried to research and stress is that over 50% of people with Down syndrome are going to have some type of thyroid condition, right? And
Mhm.
alopecia areata, vitiligo, like those all kind of walk together. So, making sure that when you diagnose something like alopecia areata or vitiligo, that your patients with Down syndrome are up to date on their thyroid screening, which, there's specific guidelines through the American Academy of Pediatrics, and there were guidelines published in JAMA a couple years ago. But it's really easy, guys. Like they need to have basically annual thyroid
Yeah.
screening. That's it. Like just make sure it's there. And as more and more, Down syndrome centers are not really available to patients. I don't want people to be like, oh, well, that's their generalist or their Down syndrome clinic's
Mm.
like job. Like it's your job. Like check it.
We're the quarterbacks on this one.
You're the quarterbacks on that one. Yeah. And you will have patients come in and see you for skin issues, and they have not had their thyroid testing for like 3 or 4 years. And so we need to be the quarterbacks there because all these autoimmune conditions kind of walk together.
Do you, I think it's a lost art, but do you actually check thyroids on a physical exam basis on your patients? And have you gotten better at it, or is it a skill that's sort of faded? I feel like I don't want to sound like an old timer, but I have a hard time seeing some of the medical students that come through and even some of the residents, unless you push them, like you can check a thyroid, you can feel for a nodule, you can get an idea if there's a fullness there, but it's sort of easier to get the test now. But it sounds like we have to get the
Yeah,
test anyway.
totally. No, I mean, well, here's the thing. I'm the daughter of a primary care doctor, so
Ooh,
I like, of course, we want to try to be hands-on to
yeah,
test for those things. And it's the same thing when we see a baby with multiple hemangiomas. Guess what? Like, you remember how to palpate for a liver. Of course, you're still going to get the liver ultrasound, but you
yeah.
should be like using those skills. So yeah. Now, am I like, oh, your thyroid feels great. I'm not going to check that
Yeah,
that thyroid study. Like, no, but I agree with you. Like, we are physicians at heart here, and we can use our hands and our brains for other organs than the skin, even though it's all our favorites. So yeah, yep.
I feel like when I do a thyroid exam on any patient, let alone Down syndrome patients, I feel like there is a little bit extra buy-in from whoever also is in the room, the parent or any other family
Hmm.
members. Like, what is this person doing? And it's really spending some time. Some of the dermatology appointments we get, maybe 5, 10 minutes for follow-up. If that's all you get, and you're doing some extra things that they've never seen done to their patients, that wow, they take that back and go, that was a real comprehensive exam. Even like you said, even if at the end of the day we're still just going to get the labs, but it gives them a
Right.
little bit more of a personal
Yeah.
feeling, I think. So it's kind of cool.
Yeah, totally. I mean, and I was explaining this to a medical student about a week or so ago that I try very hard when I know something is not infectious, to take time to
Mm.
put hands on their skin condition and touch them in like a very respectful but purposeful way so that they understand that what they have is okay,
I love it.
and they feel like we've taken time to really look at it and understand it and want to be a part of making it better, and not that they're this anomaly. And I mean, so many kids say that to us, right? In pediatrics, it's like people think my vitiligo is disgusting and contagious. Well, touch it and tell them it's okay.
Sure. Yeah.
Put hands on it, take that extra time.
I try not even to, well, more directly, I try to eradicate the use of disease in our clinic.
Right,
The term disease. This is a condition,
right.
or it's just a finding, really.
Yeah.
That helps a little bit. You mentioned alopecia areata and vitiligo being
Hmm.
more common together, and I think that
Hmm.
speaks a little bit to some of the amazing treatments that are emerging now. But what's the underlying link? How can we possibly explain why these two conditions are showing up more in a Down syndrome population?
Yeah, so I think well, we're going to go back to the 21st chromosome, right? And again,
Mhm.
they have all the other ones too. So you still need to take a thorough family history and make sure that there aren't other risk factors. But it goes back to interferon. It goes back to apiced, and that's on the 21st chromosome. And so I think there's a link there, and we're probably going to discover more and more things in the coming years. But that's why, when we talk about JAK inhibitors, I
There you go.
have patients, with Down syndrome who have alopecia areata, who I do have on JAK inhibitors, and they've done
They're
really
doing great.
well,
Yeah.
in terms of their treatment response to their alopecia areata. Um, and so far, right? And I have a small N. I'm not going to be like, no side effects, right? But
Mm.
like overall, they've done well. Um, JAK1 seems to be the thing to hit for these patients,
Yes.
trying as much as we can not to touch JAK2, although we're limited with what we have right now to always just target one.
And why is
Um,
that? I think that's a really important point. Why
yeah,
are we
the
focused on Jack one?
effect, the if so, and maybe I'll just say why not Jack 2 is
That's fair.
because we see, kind of more impacts on the white blood cell counts, and I have had that issue in several of my patients
Mm.
that when they're on these combined jacks that their white blood cell count tends to, go lower.
Plummet, yeah.
But it's just like, it's immune specific. And maybe that's why we don't see as much vitiligo because that's more of a JAK3 and we kind of see more JAK1 stuff. Gosh, Dr. King's JAK inhibitor talk at the AAD was awesome. And he had some like beautiful diagrams, as did many of the speakers, showing all the different JAK, tick stat pathways.
Mhm.
And it seems like when we're talking about interferon that it is predominantly kind of more JAK1, JAK2, but we want to stay away from pressure with the JAK2 because of the effects on blood cell counts. So,
You mentioned that both alopecia areata, I think, was predominantly what you were talking about, but these two
mm-hmm,
conditions do tend to show up earlier in these
mm-hmm.
patients. Again, we're going to play the what do we do with the age indications problem.
Right.
So, are you
Yeah.
finding success making an argument that if the patient has alopecia areata and needs a JAK, they're not meeting an age indication that's official? Are you
Mm-hmm.
getting anywhere behind the scenes with the insurance companies to allow you to start, or are you finding other ways to get that medication to your patients?
Yeah, so I think in the cases where I have had to prescribe it off label, it's kind of what we chatted about before that I just need to get somebody to listen to me at the insurance
Mhm.
company and usually do have good success, more so with baricitinib because there's more pediatric data for that, even though it's not covered, or approved right now
Right.
until you're over the age of 18. But I think that's going to change that's going to change shortly.
Mhm.
Now, and I think we need to think about this a little bit differently with some of the discoveries that we've made with alopecia areata and the timing of JAKs. But I would say that there are a fair number of patients and parents where I will describe, right? I'll be at the restaurant, I'll explain the whole menu, and they decide like they're not
Yeah.
interested in treatment, and
Right.
and that's okay. Um, that is their decision. I want them to make that decision with good information and not have it offered, not have it not offered to them. Oral minoxidil potentially also has a role here too. Now, it's not going to be as immunologically specific with their interferon dysfunction. But talk about that. You're going to have to talk with their cardiologist, right? So think about all the big organ systems and then look at their problem list and make sure that everybody's okay going on those medications. But
Just
yeah,
also
so
remember with the minoxidil, also just remembering what you mentioned earlier about riding a lower blood pressure at baseline.
right.
If you're
Yep.
stacking that on spironolactone and
You
uh,
got
you,
it.
yeah, you got to be
Yep,
careful.
you
But
got to be careful. But yeah, so I think as more options, indications become available to us with JAKs, I think we need to pay attention to all the work that's being done out in Colorado and at the NIH with the JAK inhibitors. But I think that they're, going to be a really nice treatment option for a lot of our patients. Now, a lot of the clinical trials, really all of them have been with tofacitinib in the Down syndrome population because that's what was kind of available at the when these
or
trials were being designed. But we can use some of these other ones, because I can't get tofacitinib covered. I'm
no,
not a rheumatologist,
right.
and it has more side effects compared to some of the other JAKs that we have.
Shifting gears just slightly to some other skin conditions that are a little bit more common in the Down syndrome population. One was one that I think you mentioned, if I heard you correctly. Did you say onychomycosis earlier?
Yes,
Yeah.
yeah,
Any
yep.
that one I'm having a hard time in my brain just trying to figure out why that might be, or if I've even experienced or noticed it. So, what's the underlying thought there?
Yeah, so there we go again. I sound like such a broken record. It's immune system driven. There's been some nice work at the NIH about that. It's just something, as a kind of clinical dermatologist, if you're looking for the clinical pearl, is take off all kids' shoes and look at their feet. You will find it in like a 5 or 6 year old. You're
Hmm.
like, what, because that's not something that we
That's not normal.
frequently. Yeah, that's not, our routine practice. Um, and you will find it and maybe it'll start out as tinea pedis in a little
Mm.
kid, right? And then it'll creep up into the toenails. So yeah, we talk a lot about foot care in my clinic. We talk about how for them, onychomycosis or dermatophyte infections is a chronic illness that
Mhm.
I don't necessarily have the magic thing that's going to keep it gone and away forever, but there's a whole lot of preventative treatments for it. I've had patients come in who've had it for years and like they're really into swim and Special Olympics and they don't want to do it anymore because they're
Mhm.
embarrassed by their feet, because no one's ever chatted about it with them. So it's definitely a skin condition that is bothering them and is not paid attention to. Um, and I'm happy if you would like Dr. K to go into kind of some of my approach with topicals,
I
with
was going to ask,
that.
is there
Yeah.
any reason that we're not using terbinafine on a daily basis, just like we would normally, or are we doing
Yeah.
topicals? What's your
Oh
approach?
yeah, so I go through the menu. I mean,
Hmm.
for the more mild localized cases, I'll oftentimes so I always do a nail clipping, both PAS and
Sure.
for culture, just to confirm diagnosis.
Mhm.
But also because it kind of gives us a little bit of muscle towards the insurance company.
Hmm.
We're oftentimes we have to start, if we're going to start with topicals, usually with topical cyclopirox. Kids are more responsive to that than adults. But I'll see them back, in about 3 months and see how effective it is. And if it's not, I tend to go over to Jublia, which
Okay.
does seem to be a bit more effective. It's
Wow.
a bear to sometimes get covered by insurance,
Yeah.
and we have to navigate that. But again, maybe not complete clinical cure for patients, but significant thinning, not
Mhm.
as uncomfortable, and after you treat their tinea pedis and you maintain them on Jublia, like they're happy, they're
Yeah.
doing well. Okay. I do use terbinafine.
Hmm.
In fact, I prescribed it twice this week, or
Yeah.
refilled it twice for
Okay.
two of my patients with Down syndrome. But again, you need to make sure that you explain to them and their caretakers, like, there's a 50% chance of recurrence. Like,
Mhm.
we're doing this to kind of get ahead of it, but we may still have to do some topicals in the future. Now, I have some patients where it just completely goes away. Um, but team sport here, right? Like, think about their liver. I do check their liver, so I check it at baseline and I usually check it 4 to 6 weeks after they're on the medication. Thinking about a 3 month course, but I will sometimes pulse it,
Okay.
week on, week off.
That's your approach.
And
Okay.
I have good success with it. Overall, they do well with it. Gosh, knock on wood, I've not really had any issues. I've identified fatty liver disease before
Oh,
starting it in some of my patients.
okay.
Um, but yeah, and I'll use it both in pediatric and adult patients, much like we do in our pediatric dermatology practice. So, yeah, I don't know if you use topical urea, but
Hmm.
I will use that, have them apply that first and then the topical on top, or even the urea while they're on
Yeah.
terbinafine, just to kind of thin some of the hyperkeratosis, thickening of the nail that we see with
I
onychomycosis.
will. The urea problem for us is insurance coverage, but
Of
I found
course.
oh, well,
Yeah.
but I found an easy workaround on this one. I don't know if it's kosher to say, but I mean, you can pretty much get anything you want off of
Oh,
Amazon.com.
100%. Oh
I,
my gosh. If you
well, it's
had been
funny
in
that
my
you said
inbox this
100%.
morning, I
I,
did that.
I think it's funny you said 100% because
Yeah, yeah.
just 2 days ago, I don't know why it popped up when I was looking on Amazon, but 60% urea. I didn't even know that existed. But
Yeah, I
you
know I've
could,
seen that one. It's like 2% sal acid,
yes,
60% urea. I'm like,
yeah.
okay. All right. All right. Here we
That seems
go.
pretty strong. Maybe,
Yeah.
maybe a little, but Okay. But yeah, so I just have them buy that
Right.
and get it that way and avoid the
Yep.
whole nonsense. But
Yep. Yeah.
I think in your talk at SPD, you also mentioned that atopic dermatitis and eczema are a little bit more common or a lot more common in Down syndrome populations. Did I hear that correctly or not?
Yeah, so this is where I'm going to go a little bit rogue, and I'm going to say
Ooh,
Kristen Holland is probably going to back me up on this, and some
okay.
of my other colleagues that, I am not so convinced that there's more atopic dermatitis. I know that that's been reported. I have two patients of mine with Down syndrome who have it, but guess what? I take care of all their siblings too with atopic
They've
dermatitis.
got
So
it.
again, they have other chromosomes, right?
Right.
So I don't, true atopy allergy, like that's actually less common in people with Down syndrome. I would argue that I see a lot of dry skin, like
Dry skin.
significant dry skin, and with that irritant contact and sometimes allergic contact dermatitis. And I see a lot of hyperkeratosis,
Mm,
like buildup of dead dry skin, dorsal hands, elbows, knees, and it's not a psoriasiform dermatitis.
right.
It is truly hyperkeratosis, like true atopic dermatitis in my
Hmm.
Down syndrome clinic. I don't see it. I
Not the
personally
same.
don't see it.
Okay.
Maybe some other people might see differently, but as a morphology purist, trained by Rob Sidbury, like, I don't know. I
Okay.
don't think that they have a whole lot of, Th2 atopic
Yeah.
dermatitis.
I would say anecdotally, if you ha ask me what inflammatory skin condition I see more is maybe seb derm.
Oh my gosh,
Yeah.
subderm, unbelievable. Oh
Yeah.
yeah.
So almost all my
Oh
patients
yeah.
have at least
Oh,
ketoconazole shampoo as a body wash. And
100%. I see some of those kids as they get into teenage adult years,
Mhm.
they go into psoriasis,
Right. Exactly. Yeah.
So subderm, oh my gosh, almost all of my patients. I see pityrosporum
Yes.
folliculitis too in those patients and
Absolutely.
just using the keto that way. So I'm excited. In the next year or two, we're actually, we're hoping to do a microbiome study in my
Okay.
clinic to try to understand pityrosporum more on their
Cool.
skin. We have a great new PhD microbiologist here who wants to help us with that.
Well,
So,
that's a great
yep,
resource.
subderm is a big deal.
Maybe a couple conditions that I know are more prevalent in Down syndrome than others, where it's not necessarily a big deal. And actually, most of the time, I'm just counseling families. Um, Cutis marmorata and
Hmm.
acrocyanosis. Patients come
Hmm.
in, or the families come in. What is this something we should be concerned about? What's your sort of
I would
spiel?
say, yeah, so I say that this is kind of a common thing that we see in people with Down syndrome. It's oftentimes more notable when they're younger. It might get a little less notable when they're adults, but like it is something that's probably going to hang around. And then I say, if you Dr. Google this, you're going to see two things. Number
Right.
one, that this is a sign of like a cardiovascular heart condition. And then, I do make sure that I go through and be like, oh, have you had a congenital heart
Yes.
repair? How's your last, echocardiogram cardiology follow-up gone? It's great. They're great. They're doing Zumba and like also it's like, okay, we're not worried about this being
Right.
a cardiovascular sign. And then I also say you might see something about a rheumatology condition, or lupus or stuff like that, and you have no other signs of that. So yeah, so a lot of reassurance, but touching on the things that might be worrisome to them with what they read. And then I usually just end with, what else are you worried about with this?
Yep.
I
That's
have adult patients who just don't like the way it looks and
mhm.
and I get it.
Well, and that's a perfect segue. You mentioned EPS, elastosis perforans or piginosa. I
Hmm.
think probably I don't know if you're going to call it structural or not, but the thing that I probably hear more about than anything are the syringomas and what
Oh, I know.
like what do I do? I mean, I'd love to get before I tell you what I do, which is not much other than I mean, we offer procedural treatment, but what is there anything that works to prevent these things? Anything that we can do that's easy? Give me something.
Yeah, I don't know if I have it.
Yeah, it's tough.
Um,
Do your patients ask about it? And
hmm
yeah,
hmm Yeah, my female patients in
yeah,
particular. It's tough. I've read about, and then we're just going to sound like our routine dermatologist, but like sun protection, like I
Yeah.
think there is a role for that because it does affect, elastin and collagen. I have found sometimes, mild application of topical retinoids can
Hmm.
can can be somewhat helpful.
That's yeah.
Ablative techniques like for the bigger ones, but this is when I'm like, you can be mad at me. I don't have a lot to offer you. So I'd love to hear what your approach is, but I have not found anything magical.
I mean, you hit the two retinoids to try to
Hmm.
prevent. Although I'm interested, in the back of my mind, I was thinking just as we were talking, like, I wonder if zinc would have any role. I don't
Yeah,
think
that's
so,
a
but
great thought.
could
Yeah.
it? I mean, it would be neat
Hmm.
to see those patients that are on zinc supplementation not getting as much syringomas, but I
Right.
can't connect the dots. And then, we've got some fractional CO2 lasers that we can turn into more ablative, fully ablative, and just sniper off those things. But man, being blunt, it's tough. We don't even try to really do that in the exam room. It's got to go to the OR, and I hate that. But
Hmm.
it's just around the eyes, and you never know what's going to happen with any patient. And once you start, you kind of have to finish, or what's the point?
Right.
So, yeah, that's it. But it's very rare that I'm ablating off syringomas. So
Yeah,
it's
yeah. I
just
will say too, I've had a few cases too, and it's not been immediately diagnosed that they definitely have eruptive syringomas.
mm,
So they'll have them on their chest, their shoulders, sometimes their legs, and that is reported in the literature with Down syndrome. But I've definitely seen that in my clinic. So we got to understand the pathophysiology for that better. Hopefully, with that elimination of what, is causing this, we'll have more treatment options. But I wish I had the magic. Just like I wish I had the magic to cure KP for everybody, but I don't have it.
would love to get your perspective on how you set up historically and also currently in its current size, how you set up a clinic for Down syndrome patients. How did you get that notion and where did you begin? Because I'm sure other people out there are now thinking, geez, this really makes sense. I think I could do this myself.
Hmm. Yeah, so I mean, my clinic is not very old, but I think it was born out of a need for more time and better coordinated care, and just not wanting to feel rushed. I think
Mm.
that was the big thing, so that we could provide, the best care possible to patients. So. The other thing is, and I kind of had this notion too that I came from Boston Children's, MGH, and
Mhm.
UMass. All of them have dedicated Down syndrome
Oh,
clinics, like multidisciplinary clinics. So then I went up to Dartmouth and Manchester, and like, no offense to our cute little state, but like, we don't have a Down syndrome clinic, right? So I was like, oh man, there's no way I'm going to be able to do this. Well, that's totally not true. So, to everybody out there, if you don't have a Down syndrome program at wherever you are, it does not mean that you cannot have a Down syndrome dermatology clinic. Okay. Now, when I got started, I definitely linked up with all of the primary care providers
mhm.
in at Dartmouth who tend to see more people with Down syndrome,
Smart.
and
Yeah.
also in the community, just being like, hey, this is me.
Mm.
The folks down in Boston and Worcester and Maine, they all kind of in Vermont, they all kind of know me too. But these patients are getting healthcare not in subspecialty Down syndrome clinics. And you just kind of need to know who those people are in your community. Okay.
Mhm.
Now, for me personally, right now, my Down syndrome clinic is once a month.
Okay.
It is a completely dedicated day. Okay.
Mm.
Everybody, whether you are a new patient or a follow-up, gets an hour visit.
Wow.
And yeah, and Dartmouth has been
Okay.
awesome
Go
about
Dartmouth.
that. Yeah, okay. Um, I have a couple nurses who work in that clinic, but I really have one, Chelsea Merrill, who's just like amazing. And
Good job, Chelsea.
yeah, right. Like she makes the magic happen, right? So she's the first interface, with our clinic, with the
Mhm.
patient and the family. And she, just through us working together, does an exquisite job of making people feel comfortable in having zero assumptions, right? In
Yeah.
terms of the involvement of that patient in their care, because above all else, they are your patient,
Right.
not their caretakers. And so I think, and that really sets the tone is like, we're here to take care of you.
Hmm.
We are not in a rush. You need to lead us, being the patient, like, what's going on here,
Yeah.
okay? And so typically, Chelsea will do a 15, 20-minute intake, a while, and really get to know the patient, not only for what their skin condition is, but who's with them, who their caretakers are, where are they during the day, kind of all those nuts and bolts, right?
Hmm.
That we all know as pediatricians are the make or break thing for something to be successful for their
Sure.
care, right? Oftentimes when we do this intake, almost always like people stay in their clothes. We don't have them go in and be like, all right, get in a gown,
Again,
right?
again, yeah.
That is like
Gown's the
just
worst.
no, like we want them to feel like open and comfortable. And then typically she will come out, we'll chat about the patient for a while. I'll go back in.
Hmm.
They will still not be in a gown yet, and we'll kind
Hmm.
of talk, review things that we chatted about, and then I step out and they get into a gown. Now,
Okay.
the,
And up to this point, you've
yeah.
not done a physical. This is just establishing rapport, right?
Right.
Okay.
Establishing rapport. Now, for some of my more established patients and ones who don't mind taking their clothes off, and I certainly have patients like that, like
Hmm.
they don't care. They want to get in a gown right away. But like,
Right.
this is for the initial, interview with them. And so yeah, and then I very purposefully try to ask about hearing or
Okay.
like get an idea from their chart about their hearing, as does
Mhm.
Chelsea, and also like iPad communication devices. Like those are so often
Mhm.
when we're in those rush 15-minute appointments, we don't think about those things, but we really, really, really need to do that, to establish best care with them. And then at least for a new patient, I'm a huge advocate of a head to toe thorough skin exam because
Right.
as we were talking about, it's like they might
Mhm.
be coming in for a dermatofibroma, but oh my gosh, you have horrible tinnitus and you have dandruff everywhere. Guess what?
Yeah,
Like we can
we can
help
help.
with that. Oftentimes what I will do is say like, what do you want to prioritize?
Mm.
Like what are your two top things that you want to prioritize? And we're really going to try to focus and treat those so to not be overwhelming that they're leaving the office with like 16 different prescriptions, right? And like, what do I do when, where, and how?
Mhm.
Okay. And that's why initially I was like, oh, half-hour follow-ups should be enough. Oh no. Like the follow-ups oftentimes take longer because you are addressing additional skin
Right.
conditions that you didn't get to in the first visit, or they're having, they need treatment escalation or not. And means sometimes the follow-ups are 15 minutes and it's like everybody's happy. But the biggest thing that I want to say is like I never want to feel rushed
Mm.
because that really impacts, the treatment plan and just the whole rapport.
Thanks for tuning in to this episode of the Don't Be Rash Pediatric Dermatology Show, official podcast of the Society for Pediatric Dermatology. I'm your host, Dr. Andrew Krakowski. Don't forget to subscribe to our show on your favorite podcast platform and check out don'tberash.org for more information. A special thank you to our nonprofit sponsor, the Society for Pediatric Dermatology, for making this episode possible. Please make sure to check out pedsderm.net to find a pediatric dermatologist near you and to access all of the amazing science-supported, fact-based resources that the organization offers its members and the public at large. Until next time, remember, keep calm and don't be rash.